Right, okay, good evening everybody. My name is Neil Loach. I'm the president of IOH. I'm delighted to welcome you this evening to, I think it's about our 13th or 14th session this evening, and Lynn will probably tell me whether it is 13th or 14th. I think it's something like that anyway. And tonight's session, I'm delighted to welcome Tom Middleton and Catherine Goff from Connect Health. And they're going to be talking to us this evening about Ehlers Danlos syndrome, which is hypermobility type condition. So without further ado, I'll hand you over to Tom and Catherine. Thank you, guys.
Hi, everybody. I'm just going to share my screen and pop a PowerPoint on. And if someone can maybe let me know if they can see it okay. Okay, how's that?
That's great, Tom.
You can see that now. Fantastic. Okay, great. So, yeah, my name's Tom Middleton. I work as an advanced practice MSK physiotherapist for Connect Health, and I work in an NHS setting. A couple of years ago, I started to develop an interest in hypermobility and Ehlers Danlos syndrome after attending a hypermobility workshop day in one of the local rheumatology departments. And since then, I was able to undergo some further training through the EDS Society. And I really just take any opportunity I can to try and raise awareness about this condition, because hypermobility and Ehlers Danlos syndrome can be a really confusing, challenging area for both health professionals and for patients. So very briefly, a little bit about Connect Health. So they're the largest specialist MSK provider of healthcare services in the UK. And they employ over 500 clinicians, treating over 350,000 individuals each year. And they've got 4 complementary business streams of occupational health, NHS community services that I work in, IAPT, which is psychological therapies and pain management. And then they deliver services across the UK, and including 26 NHS CCGs and over 100 commercial sites. So objectives for today's session. Hopefully everyone will be really happy with what's hypermobility spectrum disorder and Ehlers Danlos syndrome, to understand the challenges facing people with EDS and I'll say HSD instead of me keeping on saying hypermobility spectrum disorder. To also have an awareness of the associated non-MSK manifestations and recommendations for assessment and management. So just to begin with, quick quiz. So if you want to pop your answers in the chat, and maybe Neil or Lynn may be able to just tell me kind of what most people what the general consensus is. So first question, does hypermobility lead to an increased risk of chronic MSK pain in young people? So if you think A, no it doesn't, B, it increases the risk 2 times, C 4 times, or D 6 times. So
well, we've had 2 guesses so far, 3.
Okay, yeah.
A couple of Ds, 1 B and 1 C.
Okay.
And another C.
Yeah. So most people think yes, it does increase that risk. Okay. So yeah, anyone who said B, yeah, it increases that risk by 2 times. So next question, when combined with obesity, so if someone's got hypermobility and obesity in young people, what does that increase the risk by? 5.1, 7.1 times, 9.1 times, or 11.1 times? So again, pop your answers in the chat.
We've got 2 C's, 2 D's and 1 B, another couple of C's,
Yeah, so bit of an even spread here. It's actually 11.1 times.
Goodness me.
Next question, people with Ehlers Danlos syndrome are how many more times more likely to have ADHD, so attention deficit hyperactivity disorder? Are they 2.6 times, 3.6 times, 4.6 times, or 5.6 times? Are you getting some answers through there, Neil?
We are. It's a real mix. B's and C's. I think C is probably the highest at the moment. A couple of A's, a couple of B's.
Yeah, it's actually D, 5.6 times more likely. And then the last question, people with Ehlers Danlos syndrome are 7.2 times more likely to have, so A is autistic spectrum disorder, B, fibromyalgia syndrome, C, rheumatoid arthritis, or D, a total knee replacement.
I think we've got mainly B's and one C.
Mainly B's and C, okay. So most people thinking fibromyalgia syndrome. Okay, it's actually autistic spectrum disorder.
Wow.
So, yeah, I mean, I find those quite surprising myself. I don't know if you do. So, what is hypermobility spectrum disorder? So, hypermobility simply is just a joint which has an excess range of movement. And so for the vast majority of people, this is of no medical consequence. They just have joints that move slightly more than usual. In some cases, this can be quite advantageous in some sports, swimming, gymnastics, dance. Hypermobility can be localized to just a joint or a pair of joints, for example, just the hips. It can be just affecting peripheral joints, so the hands and feet. It can be generalized, so throughout the body, or it can be historical, so somebody who was hypermobile and they've stiffened up as they've got older and they're not anymore. So it can be simple, but it can also be part of a more complex diagnosis, more part of a syndrome, and it can also be a clue to an underlying connective tissue disorder. Some secondary MSK manifestations, so problems associated with hypermobility, are macro trauma, so that might be joint dislocations or subluxations. Also micro trauma, so over time, if someone is hypermobile, they may have repeated micro trauma to some soft tissues or a joint, which might lead to persistent pain or osteoarthritis in that joint. So often people can have chronic pain associated with that. Also, it's common to have reduced proprioception, so that joint position sense, which can sometimes lead to increased injuries. And also, it's common to have MSK traits like flat feet, misaligned toes or elbows, or spinal curves, scoliosis, or mild to moderate scoliosis or kyphosis. So these are the MSK things which can be associated. And there's also a growing recognition of a whole host of non-MSK problems associated. Some of the non-associated MSK problems, and we're going to dive into these in a little bit more detail later in the talk. So anxiety disorders, such as panic disorder or agoraphobia, cardiovascular disorders and dysautonomia, which is a dysregulation of that autonomic nervous system. So that's all your automatic things like your heart rate, blood pressure, digestion and things. Bowel problems, such as sluggish bowels, very common, hernia, refluxes, chronic inflammation. Short-sightedness, pelvic floor problems as well, including chronic bladder inflammation. Often people can have a heavy, painful menstrual cycles and a sensitivity to progesterone, which can worsen the MSK symptoms. And in pregnancy, people with EDS are at a much higher risk of having things like pelvic girdle problems. So, sorry, I didn't really say at the start, but also we've got time for questions at the end, but I'm more than happy for people to pop questions in the chat or ask me questions throughout the talk as well. So, so do feel free to chip in. So, simply assessing hypermobility. You may be familiar with this, you may not. Just the Baton score. So it's just a 9-point score, and it's you get 1 point for each little finger that bends past 90 degrees, 1 point for each thumb that reaches the forearm, 1 point for each elbow and for each knee that hyperextends past 10 degrees, and then 1 point for putting your hands flat on the floor. And so for most adults, it's a score of 5 or more to be diagnosed with general hypermobility. There's also something called the 5-point questionnaire, which can be used to assess hypermobility. So if you have 2 or more positive questions, answers from the 5-point questionnaire, that's got an 85% sensitivity and specificity for hypermobility. So on the Baton score, if someone's just a little bit below, just maybe a point below, you can follow it up with a 5-point questionnaire. So if someone has a positive Baton score and they've got 1 or more associated MSK manifestation, then a hypermobility spectrum disorder can be diagnosed. And to be a bit more specific, we could say that that's generalized, localized, peripheral, or historical. If someone has generalized hypermobility spectrum disorder, we also want to think, could this person have hypermobile Ehlers Danlos syndrome? And we're going to talk a little bit more about that in a few minutes. Now, for those of you who've treated people or know people who have Ehlers Danlos syndrome, or if you have it yourself, or hypermobility spectrum disorder, you'll know there's a whole host of challenges. Reduced participation is really common with these patients, and that's at work, at school, in sport, in social occasions. People will often have multiple diagnoses, so they may be diagnosed with hypermobility or Ehlers Danlos syndrome, but often also fibromyalgia, chronic fatigue, arthritis, and they may have quite a few diagnoses already. They'll often have multiple sites of pain. There's considerable overlap between these different conditions. This can be really confusing for health professionals and for patients. There's considerable variability. So someone with hypermobility spectrum disorder or EDS will have a completely different set of symptoms to another person. And over their lifespan, those symptoms can vary a lot as well. There's a lot of confusing terminology out there, which we're going to talk about in a minute. And there's very few specialist services for hypermobility and EDS in the country. So these patients are complex, there are multiple systems often involved, which means they're under multiple services for treatment often. And all of this can leave us and patients looking a little bit like this lady tearing her hair out. Fortunately, things are getting much clearer, and in 2016, the Ehlers Danlos Society had an international symposium in New York, and they had over 200 health professionals and patients who got together, and their primary goal was to reclassify the diagnostic criteria for all of the EDS types. And as a result of this, there were 18 publications in the American Journal of Medical Genetics, and they're all accessible on the EDS website. So they came up with a diagnostic criteria for 13 subtypes of EDS, and they also published care guidelines for the associated comorbidities. So really useful resource there. And they also proposed this term hypermobility spectrum disorders. In medical notes, you'll often come across quite a variety of different terms. So benign joint hypermobility syndrome, generalized joint hypermobility, EDS type 3 hypermobility type, joint laxity disorder, and these can be pretty confusing. These can also be quite, I know I've spoken to a couple of patients who really did not like the term benign joint hypermobility syndrome, because for them what they're experiencing is far from benign. So after the EDS summit, they've really encouraged people not to use them, and they've agreed on the terms generalized joint hypermobility, which we spoke about before, hypermobile Ehlers Danlos syndrome, and hypermobility spectrum disorder. And this has made research a lot, facilitated a lot of research in the area, having these agreed upon terms as well. I really encourage you to try to use these terms as well going forwards. So what are the Ehlers Danlos syndromes? So these are a group of inherited connective tissue disorders, and there's 13 subtypes. They're all to do with abnormal structure or function of the connective tissue collagen, the different types of collagen in the body, or these sort of associated connective tissue proteins. And because of the different types of collagen are affected, or the function of the collagen or how it's synthesized, they have very, very varied effects on the body depending on what type of EDS. So some are very widespread, some affect more vascular tissues, some affect more joints, some teeth, some eyes. And for 12 of 13 of these, they've identified the genetic faults, so they can be confirmed with genetic tests. There is substantial overlap between these conditions and other connective tissue disorders and variability. And the Ehlers-Danlos syndromes are mainly characterized by joint hypermobility, skin stretchiness, and tissue fragility. So these are the 13 subtypes. You've got the name of the subtype, the inheritance pattern, the genetic marker, and then the protein involved, collagen involved. And as you'll notice, hypermobile EDS, it's unknown. And this is by far the most common type of EDS that you'll come across. Some of these other ones are classed as rare or extremely rare, so kind of 1 in a million. And these are the other types. I'm not going to go into all of these by any means. We're mainly going to talk about hypermobile EDS, which is the one you'll see, and touch upon some of the other more common ones. So what's the difference between hypermobile spectrum disorder and hypermobile EDS? Well, it's a continuum, and we can simply put from on the left of your screen, so the green arrow, this is someone who's just hypermobile with no symptoms. We've then got hypermobility spectrum disorder, and then at a certain point, a line was drawn in the sand, and then that's the 2017 criteria. And then after that point, someone has got hypermobile EDS, and their symptoms are that kind of marked. Now, we're going to talk about that criteria, but you might ask, well, pre-2017, what happened to all the people diagnosed with EDS who don't meet that criteria? Well, they keep that diagnosis. They're still diagnosed with hypermobile EDS. But essentially what's happened is it's become more difficult to get diagnosed with hypermobile EDS than it once was. This diagram, I thought, just as well illustrates the relationships quite nicely. So on this left side of the screen, we've got generalized joint hypermobility, which is part of a bigger family of just asymptomatic joint hypermobility. And then we've got hypermobile EDS, which is part of the bigger family of Ehlers Danlos syndromes. And then we've got the hypermobility spectrum disorders, which can be localized, peripheral, general, historical. And then we've got these associated comorbidities, so psychological distress, the pelvic and bladder dysfunction, the gastrointestinal dysfunction, and POTS, which is postural orthostatic tachycardia syndrome, which we'll talk about as well. So with the diagnostic criteria for hypermobile EDS, we've got there's 3 criteria, and because there isn't a genetic marker for this, there's a diagnostic criteria. So the first one, we kind of touched on this before. So does the person have generalized joint hypermobility using that simple Baton score or the 5-point questionnaire? The second criteria are looking at people's extra-articular symptoms. And this is split into features A, B, and C, and they have to have 2 or more of A, B, or C. Feature A is split up between does somebody have these connective tissue and fascia things, and also marfanoid features. So things like unusual soft velvety skin, mild skin hyperextensibility, unexplained stretch marks. These things called pysogenic papules of the heel, which I've got a picture of in a minute, essentially little white nodule kind of things on the heel. Recurrent or multiple abdominal hernias, and then atrophic scarring of the skin of at least 2 sites, without these other truly kind of paper-like scars, which you'll see in a different type of EDS. And pelvic floor, rectal or uterine prolapse in children, men or women who haven't given birth, or without a history of morbid obesity or another condition. And then these are the more Marfan syndrome type things. So dental crowding, high narrow palate, arachnodactyly, which is these really long fingers. And there's a couple of tests to look at that called the wrist or Walker's sign and the thumb sign, which we'll have a picture of too. And then a few other things to do with the heart as well. Also, a positive family history, 1 or more first-degree relatives independently meeting the mobile EDS criteria. And then feature C is to do with other symptoms of Ehlers Danlos, so MSK pain, persistent widespread pain, or these recurrent joint dislocations. Just get a little bit of feedback there, maybe from someone there. That's better. So the top picture here, these are the pysogenic papules, and these are essentially the adipose tissue in your heel. If it pushes against the fascia, and there's these little maybe imperfections in the fascia that it bulges through. Imagine if you pushed your hand against a colander, you'd see little bulges coming through. You often have to get someone to stand up for them to be visible, so you might not see them if they're sat on the bed. This wrist sign is in your thumb and in your little finger meet around your wrist, and the thumb sign is if they make a fist, does the thumb poke down through the bottom? And then these are the stretch marks. And then this is the type of scarring seen in hypermobile EDS, which often looks like cigarette burns on people. And the third criteria for diagnosing hypermobile EDS is exclusion of other conditions. So they can
watch this then.
They shouldn't have an absence. Okay, so I didn't know if anyone had a question there, but I think maybe someone just not on mute. So an absence of unusual skin fragility, which should prompt consideration of other types of EDS, and then excluding any other connective tissue disorders or rheumatological disorders. So them having an appropriate assessment either in rheumatology or the clinical geneticist. And then exclusion of other diagnoses that can lead to joint hypermobility, such as neuromuscular disorders or other types of connective tissue disease as well. Just an illustration here of the other types of connective tissue disorders and where EDS sits within those. I'm by no means an expert on these other types, but we can see that they, depending on if it's collagen affected or these other types of signaling disorders, but this is usually your clinical geneticists who will be doing these types of tests. But it's just sometimes good to have an awareness of them so they're on the radar. So just briefly talking about classical EDS. So this is like another form of EDS. It's not as common, but it is one of the other more common ones. and this is characterized by significant skin hyperextensibility. So really, people can really pick up their skin and stretch it really far, and the sort of a different type of scarring and generalized hypermobility. We should maybe think about this. And they have these kind of called molluscoid pseudotumors, this type of scarring, subcutaneous spheroids, which are these little lumps, and this papyraceous scars, so cigarette paper scars, I think they're termed, so real kind of paper-like scars that people have. It's important to, sometimes there's concerns about inheriting these, and people can sort of struggle after operations and things like that to heal quite successfully. So it's often important to that people get those genetic tests if there's suspicion of classical EDS. Another really important one is vascular EDS. So if someone has had a significant vascular event, such as an internal organ or vascular rupture, such as spontaneous sigmoid colon rupture or an arterial rupture when they're quite young, under the age of 40, a punctured lung, or a family history of vascular EDS. We should sort of look for these other sort of associated signs. With vascular EDS, people will often have quite a typical look about their face, so quite widespread eyes, narrow nose, and no earlobes. This isn't every time, but sometimes. They'll often have peripheral joint hypermobility with their hands and feet. A very thin, translucent skin, so often being able to see the veins under the skin quite clearly. And really sort of extreme, sort of almost catastrophic bruising from quite minor events. Vascular EDS is an important one to look out for because it affects, I think, type 3 collagen, which is mainly large hollow vessels in your body, and people can have things like a uterine rupture in the third trimester of pregnancy, and they can have arterial rupture leading to death and things. So it's a really important one to that gets that specialist vascular input. Now, all the types we've talked about so far: hypermobile EDS, hypermobility spectrum disorder, classical and vascular EDS, all are autosomal dominant inheritance. What that means is if one parent has the condition, then the child has a 50-50 chance of having it. So it's some of the other Ehlers Danlos syndromes are autosomal recessive. So that means if one parent has it, then a child has a 25% chance of having it, a 50% chance of being a carrier, and a 25% chance they don't have it and they're not a carrier. So that asking about the family history is quite key. So the associated manifestations of hypermobility and hypermobile EDS, we touched on these before. When we're talking to someone with EDS, it's useful to think of it using a spider diagram like this. And some of the symptoms they'll have are often fatigue, there's cardiac dysautonomia, gastrointestinal or urogenital problems, anxiety, depression, MSK problems, and various types of acute or chronic pain. And what we can do is we can plot a little diagram like this to see which, for this person, are the real conditions that they're struggling with at that time. And then this can help us to prioritize how we can help and support these people. Just diving into these in a little bit more detail. So dysautonomia, cardiovascular dysautonomia, as I said, is a dysregulation of the autonomic nervous system. So that underpins your body's homeostasis processes, so your heart rate, blood pressure, digestion, bladder, stress response, sweating, etc. And the cardiovascular, there's two main presentations. So there's orthostatic hypotension, so that postural drop when people stand, and then there's POTS, postural orthostatic tachycardia syndrome, which is that abnormal increased heart rate when they go from lying to standing, or when they're just standing up for a long time. And the suggested sort of mechanisms of this are people have, if your arteries are a little bit stretchier, they may have lower blood pressure, and they don't quite get that vasoconstriction when to help get the blood back, and it can pool in the legs. We also think that there could be autoimmune and excess histamine involved as well in this, which I'm not an expert on that or how to treat that, but this is just what the experts tell me. So the ways that POTS, some of the symptoms people normally have, and the management which is often used. So the common symptoms are near syncope when they're standing, and they may have that venous pooling in their legs because the blood's not getting pushed back to where it needs to be when they stand, and often they'll get quite prolonged colour changes in their legs afterwards. Tachycardia on standing. This can result in anxiety for people, and also they can get an excessive heart rate on exercise, which can be a real barrier to them participating in exercise as well. Heat intolerance as well with the vasodilation, and often they'll have IBS or slow bowel transit. Some ways to treat it, some advice, eating smaller meals with fewer carbohydrates. Apparently a big carby meal can give you a spike in insulin, which is a vasodilator, which can exacerbate symptoms. Increasing fluid intake, avoiding caffeine, increasing salt intake, and avoiding a prolonged standing. And also ways to dial down that sympathetic nervous system with stress and anxiety can help. People can have self-management techniques, such as before they get out of bed or before they stand, after they've been sat for a while, doing some exercises to sort of pump their hands and feet to get that venous return. And then when it comes to exercise, really gradually building that up. Sometimes people find pressure garments are helpful, and certain medications can be helpful to use this to aid kind of vasoconstriction. And then also low histamine diet is apparently something which helps, which I'm not a dietitian, but the dietitians do use this, and apparently things like leftover food is quite high in histamine, so they can get advice like that as well. Now, chronic fatigue is really common in people with EDS. So over 75% of people with EDS suffer from fatigue. And it's also, according to them, one of the most disabling symptoms that people have, and it responds less well to treatment than other things such as pain. It's difficult to manage and influence with medications and cognitive interventions, and fatigue doesn't really have a clear definition. So people experience different things. They might experience muscle weakness, no energy, low motivation. Physiologically, it could be depletion of your ATP, muscle atrophy, muscle weakness, reduced cardiopulmonary function, to deconditioning and decreased movement efficiency. And then psychologically, mental exhaustion, low concentration, can't get my words out, depression, stress, and unwillingness. So it's thought to be a sensory modality, perception, and an emotion. It's difficult to treat. And if someone has 5 or more multi-system comorbidities, this is strongly predictive of them having chronicity and disablement. And the dominant feature of that is fatigue more than pain. If you think about someone with EDS, they can quite easily have more than 5 of their bodily systems involved. Now, another association is psychiatric and psychological issues. So we're discovering there's a lot of research going on in these areas, but we're discovering there's a really strong link with hypermobile EDS and hypermobility with anxiety disorders, and also these growing links to depression and neurodevelopmental disorders such as autistic spectrum disorder and ADHD. So when we're helping someone with EDS and they have these other mental health disorders, it can be really difficult, or just an added challenge as well. And then finally, there's some MSK considerations. Again, they don't know a lot of the prevalence in this. It's some ongoing research, but sometimes people can have upper cervical spine instability, which can give them kind of widespread neurological problems and require surgical opinion. They can sometimes have an increased likelihood to have a Chiari malformation, which is to do with the malformation of the brain stem, which again can give you various sort of neurological disorders and require a neurosurgical opinion. They don't know exactly how prevalent it is, but it's more common in females than males with hypermobile EDS. We talked a little bit about the joint dislocations, subluxations, and some spinal instability. And then because of the hypermobile joints as well, often there can be sort of nerve impingements or subluxations around joints, things like thoracic outlet syndrome, small vibroneuropathy, and radiculopathy. So these are some of the things to consider as well with MSK problems. So generally, a management approach that was advised from the EDS symposium in 2016 was really that holistic care approach, not just focusing on one issue. So that holistic, compassionate, empowering, evidence-based practice, education about the condition, reassurance, and signposting to relevant resources. So the EDS website is really good, and there's lots of support groups out there. Early specialist referral where necessary. So if someone comes in with hypermobility, but they've clearly got some ongoing like bladder issues, getting them seen by that specialist as soon as possible, really, to help manage their symptoms. And a clinically reasoned goal-directed functional restoration program. So usually in physio, instead of focusing on one joint, looking at their whole body and their whole function and how they can function at work or participate in school or in sport. And often physios will use a strength and conditioning and motor control principles tailored to that person. And then that multidisciplinary team involvement is key. So subjectively, we want to listen really carefully to the patient and the problems that they're experiencing, explore their expectations. Identifying the problems, often using that spider leg diagram we showed before, is helpful, and that helps us to prioritize what the key issues for that person are. Exploring the impact it's having to them on their work, their hobbies, their relationships, and identifying any barriers to their participation. The most common ones are pain, fatigue, and also fear of injury, particularly when it comes to sport or doing physio. And these patients are actually at high risk of injury, particularly if they're fatigued. So when physios get them doing exercises, they often won't push them too hard, because if they really can't control where their joint is in space, they can injure themselves. Whereas normally in physio, we'll push people until their muscles are so fatigued they stop to really build that muscle. And we also need to be thinking who else needs to be involved with this person's care. So physio, OT, podiatry, orthotics, often splinting and things is useful. Psychology, dietitians, and various medical teams as well. So objective, just assessing carefully, having a look at that Baden score and considering using the EDS diagnostic criteria. And I think, I don't know, in my profession, I can't fully diagnose someone with it because I can't exclude those other conditions, but if someone's scoring really highly, then we can refer on with that really good workup. There is a couple of, there's a lower limb and an upper limb hypermobility assessment score, which are both reliable to use. And then, as well as looking at the specific joints, looking at how they're doing functionally. So you can look at their general movements, How are they compensating? Have they got reduced balance and strength, and what's their proprioception like? And finally, we'll often find with these patients they're under multiple health professionals, and this can be difficult for us. For the patient, health professionals often sit in their own silos and don't communicate with each other. So coordinating that patient's care, we really encourage you to create a patient-centered network. So with a patient in the middle, health professionals, just like you would in an MDT, really sort of communicating, and this just really improves care for the patient. So to do that, establish who is involved in that patient's care and establish early contact. Share your findings in your treatment plan, and then you can adjust and coordinate that plan together. Okay, so hopefully that's been helpful. You've all been very quiet. I'm happy to try and answer any questions that you might have. And there's a few references, and if anyone has any Connect Health queries, Catherine Goff's on the call, and these are her details as well. Have you got any questions in the chat or anything, Neil?
Yeah, we have. Nikki, I don't know whether you want to put your microphone on. Nikki Rain has asked a question about POTS.
Okay.
Nikki, do you want to turn your microphone on? Right, okay, so I don't know whether she's able to...
Can you hear me?
Oh, yes, can hear you now, Nikki.
Hi, Tom.
Hi, Nikki.
Yeah. Actually, I could have done with this morning. I had a lady today that first time I've had anyone with POTS and EDS.
Right.
Yeah.
Okay, good. Yeah.
It's quite interesting because she had like kind of multiple things going on.
Yeah.
And her eyes were badly affected.
Okay.
Yeah.
That's
I just want to know with the POTS there. Is that? I don't know if anyone else knows this question really. I don't know, Tom, but does POTS generally go like normally? I think doesn't POTS generally go after a length of time? You don't usually have it your whole life, do you?
Really good question, and really interesting thing with. Did you say she had EDS as well?
Yeah. So I didn't know if like it was like just because it was part and parcel of the she's got POTS, or just kind of trying to work out,
Yeah. So with EDS, for example, with hypermobile EDS, or someone has POTS and with hypermobility spectrum disorder. From what I understand, symptoms can vary a lot over time. So what's really common is someone will have through their childhood or teens maybe have quite a few symptoms, and then there's usually a stressor, and that can either be a physical stressor, such as they have an injury, or their body goes through something like a pregnancy, or a significant psychological stress. And this can really bring on all these multiple other associated comorbidities, like POTS or bowel problems or bladder problems or anxiety, or the musculoskeletal problems can get worse. So it can come on at any time. And then over the course of EDS, certain symptoms can be really out of control, and then they can settle down, and another type of symptoms can flare up. So you might find that this lady's POTS become, with the right specialist advice, if she's under a cardiac team or anything like that, help her to get it under control, and it might be really well managed. But she might have something else flare up, and then POTS might flare up in the future. So with the dysautonomia, it can be quite variable from what I understand.
Yeah. I mean, I know that like as Lisa Skinner said there, that heat dehydration and illness can affect POTS, and certainly I've mentioned that, you know, to make sure she drinks plenty.
Yeah.
Try and avoid that, especially in the warmer weather, as well we have been experiencing. It's not so good today, is it?
Absolutely, yeah, yes, that's it. So on that slide I had up earlier, yeah, I think apparently the things which are commonly used, there's quite a few different techniques people can use to try and help control their POTS, and get it under control. But yeah, is that okay? Does that answer your question?
Yeah, fine, thank you.
Thanks.
Right, so Lisa has asked a question about how frequently are you seeing people in the workplace with hypermobility EDS or other types of EDS?
So, do you mean like how common is it for people to have EDS in the workplace, or how often would you want to be seeing someone with EDS at work?
Lisa, do you want to turn your microphone on?
Yeah, sorry, just to clarify, I'm an EDS sufferer.
Oh, you? Oh, okay.
I'm also an occupational health person, so it's quite interesting how a lot of people end up not at work on disability or whatever because of EDS. When with certain things in place, it's actually for some people quite possible to work, and actually quite a good thing to be able to work. And it's just interesting in that I don't come across very many people who are still working by the time they're my age with EDS. But wondering if now that there's more awareness around, whether it's becoming, people are more aware of what they need to do to keep people in the workplace with it.
That's it, exactly, Lisa. And I don't know the exact kind of prevalence of how people with EDS, how many of them are in work or out of work. But you're absolutely right. I think there's multiple reasons why people can struggle to stay in work, but hopefully in the last few years, the recognition is improving, the management's improving, and I think ultimately the more health professionals are kind of who are clued up on EDS, and if we can try and improve care, hopefully we're going to keep more people in work as well, and improve that participation in school and in our other activities as well. But a real challenge, definitely.
Sounds like a research project is needed there. So if anybody wants a dissertation about workplace health and EDS, then that's certainly something to consider. Yeah,
there's a big ongoing through the EDS Society. They're doing a big research study at the minute on hypermobile EDS, and they're creating a what's the word? Kind of a database of if people have got it, they can add their name and their symptoms and their details to help with this study. So hopefully we'll find out information like this, kind of like employment rates and things like that.
Yeah, I would be very surprised if they didn't add that question about whether they're working. And it would be a great shame if they obviously didn't. We've also got some comments from Lisa as well about heat, dehydration and illness affect POTS. And where else are we? And again, Lisa's also said that some people increase salt intake to manage POTS.
Yeah.
Okay.
Great.
Wonderful. So it doesn't look as though we've got any more questions, but there is a comment from Dawn who says that it's very interesting. She's had more cases in the last year, which has been obviously very interesting and quite a steep learning curve by the sounds of it.
Yeah, definitely. And I wonder if there's that increased awareness, more people possibly getting diagnosed, but
or is it better awareness so that people are coming forward and then obviously, you know, being diagnosed because there is more awareness for onward referral?
Definitely, and as well with that increased recognition, how many people they think that hypermobility spectrum disorder is massively underdiagnosed, a lot of other people may have previously been diagnosed with fibromyalgia or chronic fatigue syndrome when they've got this sort of connective tissue disorder underlying. So yeah, really, really interesting.
Yeah, and then Nikki's also said that the character Izzy on Coronation Street has EDS. She's the one that's the wheelchair user, I believe. Is that right?
Right, wow.
Am I right that Izzy is the woman that's in the wheelchair? Yep, thought I was. I'm not an avid Coronation Street fan of recent years, but yeah, I do remember her. So that's good, and hopefully, you know, that's raising awareness, as Nikki's pointed out as well.
Absolutely, yeah. Any high-profile celeb to raise awareness is great as well.
Yeah, I had a colleague actually that had it, who was an admin worker in occupational health, and she ended up having some hip surgery at one of the I think it was one of the orthopedic hospitals up in Manchester.
Okay.
To treat hypermobile hips.
Oh, right.
They kept popping out.
Right. Oh, that's interesting. Yeah, I think that kind of, people will have various orthopedic surgeries and things. I think particularly with feet, they can be quite, in later age, can have quite a few toe deformities and things, and often end up having a little bit of orthopedic input, from what I understand as well.
Yeah. Okay, wonderful. So are there any final questions or comments that people would like to make? And then Nikki's also said actually that she believes the actress herself has it, and they're doing a story about trying to get her back into the workplace. So yeah, that sounds good. So if there's no final questions, I'd like to offer both Catherine and Tom, and also Connect Health, our sincere gratitude for their time this evening. It might be worth telling us a little bit more about Connect Health and what services that you actually provide. So for instance, you've talked about the IAPT and obviously the community health services where you're employed, Tom, but do you do things like orthotics or podiatry and things like that as well, or is it, you know, what kind of range of services do you actually provide?
I don't know if you want to take that one, Catherine.
Yes, Tom, I'll pick that up. So yes, Connect is an organisation that was established over 30 years ago, and we started predominantly in the MSK world, although we have branched out elsewhere. I'm a physiotherapist by profession. I've worked in occupational health since 1997, when I had the benefits of being asked by Marks and Spencer's to work as a physio within their one of their sites, and it was, to be honest, it was just a light bulb moment in regards to being able to assess and treat employees, but then also being able to you know, assess the workplace. It was just best outcomes for all. It was best outcomes from the colleague, the employee, it was best outcomes from me as a physio, but it was the best outcomes for the employer as well. So we have a comprehensive service model. It's split into prevention, assessment, rehabilitation and training. And if anybody wants any further information on any of the, service streams, I'd be more than happy, to discuss that, send further information, etc. It has huge, financial saving benefits. It has huge increases engagement with colleagues. I don't need to sell that to the audience here. They're all, well aware of the benefits of occupational health and the associated services. But, if there's anything in their musculoskeletal space that you'd want to learn more about, please feel free to contact me. Obviously, my details were up on the screen earlier, or, I'm regularly on LinkedIn. Do follow me on LinkedIn. And likewise, I'll, interact with yourselves too.
Okay, wonderful. So does it include things like orthotics? Is it a full range of services that you would expect that might be useful for an employer to get involved with you for?
The physios the physios can look at biomechanics, they can look at foot problems. You know, we treat associated problems in that space. We're not podiatrists or chiropodists. No, that, you know, we don't deliver those type of services. Although we do work very, you know, we do a lot in the footwear space because we work a lot with manufacturing sites and all the footwear and the wellies and everything that comes up, you know, with that. So we're, you know, we work closely with some good footwear providers and orthotics and can advise. But in regards to the services that we deliver ourselves, no, to answer your question.
Okay, wonderful. Okay. Right. Okay, guys. So, yep, our sincere thanks for your time and obviously your expertise this evening. Thank you very much indeed.
No, thank you very much for the invite. It's very much appreciated.
Okay, I hope it's first of many.
Thank you.
Okay, thank you very much, guys. So I'm going to actually stop recording now. Bear with me. I will do that straight away.